Hi everyone, good evening. Welcome to this important session, which is specifically for all the FMG students who are going to appear for their exam in January. Now, I can see many of you are live now. Now, Bacho, your exam was postponed. Your exam was scheduled for 3rd of December and now it is postponed. So consider this time as an opportunity to complete your targets. All those subjects which you weren't able to complete and you wanted you get some extra days to complete those topics, this is the time when you are going to complete all those subjects. Make the most of this time. This is a very good opportunity for all of you. This 1.5 month, which rather abhi to you have 2 months. So this 1.5 to 2 months which you are going to use them very carefully. And you are going to see, time is the most valuable asset which all of you have got. You are not going to waste your time. You are not going to now think that I am quitting. That is not an option for you all. Rather, this is an opportunity where you can, all of you who are listening, who are watching this session, can say to yourself with conviction, ki now this 1.5 to 2 months I have got extra, I am going to clear my exam this time, right? I believe in all of you, and I'm sure you will also believe in yourself. Rather, this is what I want you to do, to believe in yourself. I want you to focus on your goal and don't look in any other direction but ahead. That is the only thing which you have to do. Keep on moving. Take those small steps, and ultimately, those small steps will take you to the other side of the exam. I want all of you to clear this exam, which is going to happen in January. And in order to help you in understanding what are the important topics for OBS and Gynae, I have brought this very important session. Now, in this session, what is planned? In this session, I am going to, discuss with you some very important MCQs. So many times you people are confused that there are sessions for INI set, there are sessions for NEET PG, and you are confused that हमें कितना पढ़ना है, how much do we people have to study, क्या हमें सारे updates जानने हैं? Now this is session which is specifically for you all, where I am going to tell you what updates you people need to know. And believe me, there are going to be questions which are going to come definitely sure shot in your FMG exams from the questions which I am going to take up today, right? Not only this, in this session, I'm going to show you some important spotters. I will be discussing those scores in OBS and Gynae which you need to know. And towards the end of the session, I will be dividing entire OBS and Gynae into three parts, right? Part one will be the one, suppose abhi tak you have not started OBS and Gynae, completing OBS, you've not started or you haven't completed OBS and Gynae, this list which I'm going to provide you is going to act as a benchmark for you. List one may the topics which I'm going to give you, those are the topics which you are going to first focus on. Once you complete those topics of list one, then you are going to go to list two. And just in case you don't have any time, but do list one and list two ke topics, that is more than enough. But if you have time, then go to list three, which I am not going to tell you what is list three. The remaining topics come in list three, right? This is going to happen towards the end of the session. So coming to the first question. Now, as per WHO parameter, for semen analysis of 2021, the following parameter remains unchanged. Now, I don't know how many of you people know. WHO ke semen analysis parameters have changed. Initially, the parameters which I have been teaching you, they were the ones which were given in 2010. And now 2021 May, the new parameters have come. And your question is, which of the following parameter remains unchanged? And I can see you have started answering. Excellent. Anand, Prasann, Sibgot, Solanki, all of you have answered this question very well. And the answer is sperm morphology, right? So this over here is WHO's 2010 parameters, and over here is WHO's 2021 parameters. जो 2021 के semen analysis के parameters हैं, they are based on 5th percentile. इससे क्या मतलब है? This means that these are the parameters which are minimum. This number represents minimum what is needed for conception. These are not the average values. So semen volume according to 2010 parameter, minimum semen volume needed for conception was 1.5 ml. Now it is 1.4 ml. Now tell me quickly, if there is no semen, what is the term called as? No semen is called as aspermia, right? Number 2, second parameter is total sperm number. Now total number of sperms, and this is minimum which is needed for conception, that is 39 million sperms, and just that also remains unchanged. Total sperm number is 39 million again. Now tell me, what do you ask? And I mean, what is the term which is used for decreased sperm count? What is the term which is used for decreased sperm count? Decreased sperm count is oligospermia, right? Oligospermia means when the sperm concentration is less than 15 million per ml. And if sperm concentration is less than 5 million per ml, that is called as severe oligospermia. And what is the term which is used for no sperms in semen? So no sperm in semen is azoospermia. Clear? Now, total motility. Total motility according to 2010 parameter was 40%. Now it is 42%. Progressive motility was 32% earlier. Now it is 30%. Please remember, what do you call the term? What is the terminology used for decreased sperm motility? The terminology used for decreased sperm motility, what is the terminology? That is asthenospermia. So you are going to tell me one very important condition in which you get asthenospermia. In which condition do you get asthenospermia? Quickly write down in the comment box and let me know. In which condition do you get asthenospermia? Asthenospermia you get in which syndrome? In immotile cilia syndrome, which is called as Cartagener's syndrome, right? Cartagener's syndrome. Now tell me, in which two very important conditions you get azoospermia? Please remember, azoospermia you are going to get in cystic fibrosis, right? And in Klinefelter's syndrome. In cystic fibrosis and Klinefelter's syndrome. Clear to all of you? That is the reason why whenever you get azoospermia, you should get a karyotyping done to rule out Klinefelter's syndrome. Clear? Now, non-progressive motility 1%, that is the criteria, both last 2010 criteria also and 2021 criteria. Immotile sperms 22%, now it is 20%. Vitality 58%, and now it is 54%. Normal forms 4%, and now still it is 4%. So morphology remains unchanged. Total sperm number remains unchanged in the 2021 criteria. Another very important question is, suppose there is and this is something which you people, tend to make mistakes. Suppose if there is a report of azoospermia, after how much time should you get a second a semen analysis done to confirm a zoospermia. So you should get a second time semen analysis done to confirm a zoospermia minimum after 1 week time, and best is after 1 month. Now the confusion here comes जब क्वेश्चन ये पूछा जाए कि there was a problem in semen analysis because of which some drug treatment was given, and because drug treatment was given, now they ask you that after how much time should you repeat a semen analysis to see whether the drug has worked or not. Now, in this type of question, remember that the total time taken for spermatogenesis is 70 to 74 days. It is basically 72 days, and the range is 70 to 74 days. Best answer is 72 days. And after that, once spermatogenesis occurs, then the sperm is going to take time to move in the ductal system, in the male ductal system. So if you have given a drug and you want to see whether its effect is coming or not, a repeat semen analysis should be done after 3 months, right? But if the report is azoospermia and you want to confirm azoospermia, then the repeat semen analysis should be done minimum after 1 week. Best is after 1 month. Is this clear to all of you? Yes? Okay. Then there is one more criteria which has been added in the new semen analysis, and that is semen odor. Earlier, this criteria was not there. Now, this criteria is there, right? So, this is the new semen analysis, WHO's 2021 semen analysis. Very, very important question, right? So, this was an update which I have given you in the form of a question. Coming to a second question. Very important is HPV vaccines. That is again a very, very important topic for all the FMG students. All are true with respect to HPV vaccine except option A, it is prepared from L1 capsid protein. Option B, Serva-Vac is bivalent. Option C, as per WHO's SAGE recommendations, females with age more than equal to 20 are given 2 doses. Option D, HPV DNA testing is not done before administering the vaccine. So option A, it is prepared from L1 capsid protein. Option B, Serva-Vac is bivalent. Option C, as per WHO's SAGE recommendations, females with age more than equal to 20 are given 2 doses. Option D, HPV DNA testing is not done before administering the vaccine. I can see all of you answering, and most of you have answered it as option D, which is incorrect. Option D is the wrong answer. Only one has answered it correctly, and that is Anchal Sharma. That is Serva-Vac is bivalent. Please be very careful. They are asking Serva-Vac, right? This is not cervix vaccine, right? This is not your Cervirax vaccine, right? It is Serva-Vac which is given to you in options over here. It's not Cervirax vaccine. Cervirax vaccine is bivalent, but Serva-Vac, that's the first quadrivalent vaccine which is being prepared by India. It's the India's first HPV vaccine, which is being prepared by, rather it has now been prepared by Serum Institute of India in Pune. And this Serva-Vac vaccine is a quadrivalent vaccine which is active against HPV 6, 11, 16 and 18, right? So do not confuse Cervirax with Serva-Vac. Cervirax is bivalent. Serva-Vac is quadrivalent. Remember, all HPV vaccines are prepared from L1 capsid proteins, right? Till now, we had only 3 vaccines, Cervirax, Gardasil, and Gardasil 9. Cervirax is a bivalent vaccine, Gardasil was a quadrivalent vaccine, and Gardasil 9 was a nonavalent vaccine. For all FMG exams, it is very important to remember or memorize all the 9 strains against which Gardasil 9 is active. Right? So 6, 11, 16, 18, 31, 33, 45, 52, and 58. Right? Now, Cervirax is active as a bivalent vaccine, which is active only against HPV 16 and 18, and so it can protect only against CIN and cancer cervix. Whereas Gardasil was also active against 6 and 11, so it can protect against genital warts and cancer cervix. Gardasil 9 can protect against genital warts and all 6 cancers which are caused by HPV. So, what are all 6 cancers which are caused by HPV? Number 1, cancer cervix. Number 2, cancer vulva. Number 3, cancer vagina in females. Number 4, in males, oral cancer, penis cancer, and anogenital cancers. So Gardasil 9 can protect against all 6 cancers, and it is a non-valent vaccine. Ideal age to give HPV vaccines is 11 to 12 years. Right? Till now, it was said that HPV vaccines can be given only between 9 age to 26. That was the age group. But now there is an extended age group, and the extended age group in high risk females is 27 to 45 years. So if a gynecologist feels that a female comes in high risk category for cancer cervix, what are those females, or who are those females who come in high risk categories? All those females who are immunocompromised, all those who have multiple sex partners, all those who have sexually transmitted diseases, right? All those who had early coitarchy, right? Or who had early childbirth. So these are the category of females who come under high risk category females for cancer cervix. Another, what are the other risk factors for cancer cervix? Smoking is one risk factor for cancer cervix, and oral combined pills is another risk factor for cancer cervix, right? Please remember that early menarche and late menopause are risk factors for endometrial cancer and ovarian cancer, right? In case of cancer cervix, early menarche and late menopause are not risk factors. It is early coitus, early age of intercourse, and early age of childbirth, which is a risk factor for cancer cervix, right? Now, so now the extended age group for giving HPV vaccines is 9 to 45 years. Ideal age still remains the same, 11 to 12 years, right? Ideally, HPV vaccines should be given before a female begins her sexual activity. But that doesn't mean that if a female has become sexually active and she has not taken HPV vaccine, then we are going to contraindicate in her. No. HPV vaccines can be given to sexually active females. This is a common myth which all of us have, that it cannot be given to sexually active females. Number 2, it can be given to females who have present or past history of HPV infection. This is the reason why HPV testing is not needed before giving the vaccine, right? So HPV testing is not needed. That's a very, very important point which you have to remember, that before giving HPV vaccine, you don't have to do any HPV test, right? The vaccine is contraindicated in pregnant females. It is safe during lactation, and its most common side effect is syncope. Now, this again is something which is nowadays being asked. Till now, we were saying that conventionally, HPV vaccines should be given as 3 doses to all those females who are more than 15 years. And to females and males who are less than 15 years, you should give 2 doses. But recently, there is a WHO SAGE recommendation on which a question has been asked in INI-SET and in NEET both. That what is the WHO SAGE recommendation for HPV vaccines? WHO SAGE recommendation said, you see, when COVID came, it was a very aggressive movement against COVID, that all the vaccines were so easily and readily available. But as far as cancer cervix is concerned, the vaccines, number 1, are not very readily available because of the high cost. And that is why India has now manufactured its first vaccine, first HPV vaccine, which is Sarvavac, right? And number two was the dosing schedule. Because 3 doses had to be taken, that is why in many females, they were not even taking these vaccines because of the cost factor and because of the dosing factor. So recently WHO said that if you are giving this vaccine to a female who's between 9 to 20 years, you can give either 1 or 2 doses, and in females who are more than 20 years, you have to give 2 doses, right? So now they have said that in general population, there is no need to give 3 doses of this vaccine. 3 doses kisme deni hai, to in which category of females you have to give 3 doses? You have to give 3 doses only if female is HIV positive. Then only you have to give 3 doses. Otherwise, if the female is more than 20 years of age, 2 doses. Less than 20 years of age, 1 or 2 doses. Is that clear? Right? So this is very, very important. HPV vaccines and everything about HPV in itself. That's very, very important, right? So what is, which is the most common HPV which can lead to cancer cervix? That is HPV 16, right? Which is the most specific HPV which leads to cancer cervix? That is HPV 18. Which HPV leads to squamous cell carcinoma? That is HPV 16. Which HPV is most commonly associated with adenocarcinoma? That is HPV 18. Right? Now, from which protein is vaccine prepared? From L1 capsid protein. Which viral proteins are needed for viral replication? E1 and E2. Which viral proteins are needed for, oncogenicity, which are responsible for its oncogenic nature? They are E6 and E7. Clear? So these are very, very important questions on HPV, which all of you should be knowing, right? Okay. Then coming to a third question, which is again related to cancer cervix, and that is, as per WHO, the target age for screening of cancer cervix is. So tell me, as per WHO, the target age for screening of cancer cervix is option A, 21 to 49 years, option B, 21 to 65 years, option C, 30 to 65 years, option D, 30 to 49 years. Again, I am getting varied answers for this question, which clearly shows that now either it shows that you are not a Maro subscriber, right? Or if you are a Maro subscriber, you have not done edition 6 revision videos. Because if you would have done edition 6 revision videos, you would have answered this question correctly. Again, I got the answer correct only from one person. Pat your back, Anchal Sharma, from my side. Give yourself a chocolate from my side. Excellent. The answer is 30 to 49 years, right? Now, remember that the screening for cancer cervix, if you are a Maro subscriber and you have read edition 5 notes, till edition 5, we were talking only about ACOG screening for cancer cervix. Recently, WHO gave its guidelines for screening of cancer cervix in resource limited country. And we are a resource limited country. So WHO की जो guidelines हैं for screening of cancer cervix, that goes with us. So we are going to follow WHO's guidelines for screening of cancer cervix. So remember that according to WHO, the age to start screening for cancer cervix is 30 years. Whereas according to ACOG, it was 21 years, right? Age to stop the screening is 50 years, whereas according to ACOG, it was 65 years. So the target population for WHO for screening, as advised by WHO, for screening of cancer cervix is 30 to 49 years. And so the answer is 30 to 49 years. Right, this is WHO's protocol for screening of cancer cervix, which is there specifically for resource limited countries. Now, WHO has advised for resource limited countries that there are two approaches for screening. Number one is a see and treat approach, and number two is a see, triage and treat approach. सी एंड ट्रीट अप्रोच का क्या मतलब है? सी एंड ट्रीट अप्रोच का मतलब है that you, when a patient comes to you for screening of cancer cervix, you are going to do a primary screening test, and that primary screening test, as advised by WHO, is HPV DNA testing. So whenever I am going to do screening for cancer cervix, which I am going to begin at 30 years of age, I am going to do HPV DNA testing. If HPV DNA testing comes out to be positive, I am not going to do any confirmatory test. Straight away, I am going to treat my patient either with cryosurgery or with LLETZ or LEAP. What is LLETZ? It is large loop excision of transformation zone. Right? So we take a copper wire, we pass electric current through it, and we excise the entire transformation zone. Why are we excising the transformation zone? Because the most common site for cancer cervix is transformation zone. What is the most common variety for cancer cervix? Squamous cell carcinoma, right? But then, can adenocarcinoma also occur in cervix? Yes, it can happen in cervix. So if someone asks you what is the most common site for adenocarcinoma of cervix, the most common site for adenocarcinoma of cervix is endocervix. Clear to all of you? अब समझ में आया कि when you are doing pap smear, why do you take two samples? One sample you are taking from transformation zone with the help of Ayer's spatula, because transformation zone pe the cancer which is most commonly going to happen will be squamous cell cancer. And number two sample you are taking with the endocervical brush, and endocervical brush से sample कहाँ से लेंगे? From endocervix. Why we are taking it from endocervix? Because adenocarcinoma की most common site is endocervix, right? So coming back to WHO's screening approaches, WHO कहता है कि in resource limited countries there can be two approaches. One is a see and treat approach. See and treat approach में the primary screening test is HPV DNA testing. Please remember, WHO pap smear नहीं कह रहा है. WHO is not saying that you have to do a pap smear as a screening test. WHO is saying that in a country like India, you have to do the screening test HPV DNA testing. Why is WHO not saying pap smear as a screening test? Because pap smear का result के बाद always you have to do colposcopy before you can treat a patient. बल्कि WHO rather is saying कि you do a screening test and treat. And pap smear कभी भी हमें result में, in pap smear, you know, whenever you do a pap smear, always it has to be followed by biopsy. That is why WHO says don't do pap smear in a country like India. Go for HPV DNA testing. If it comes out to be positive, treat your patient either with cryosurgery or with LLETZ. Now suppose it comes out to be negative. HPV DNA testing comes out to be negative. Then after how much time are you going to repeat HPV DNA test? You are going to repeat HPV DNA test in general population after 5 to 10 years, and in HIV positive population in 3 to 5 years, right? This is one approach. Second approach which is given by WHO is see, triage and treat approach. See, triage and treat approach में WHO कहता है that you do a primary screening test. The primary screening test is HPV DNA testing. If it comes out to be positive, go for a secondary screening test, and the secondary screening test is VIA. What do you mean by VIA? Visual. V stands for visual, I for inspection, A for acetic acid. Visual inspection with acetic acid. And if VIA also comes out to be positive, then you go for treatment. That is see, triage and treat approach. So in a nutshell, according to WHO, best is see, try, and treat approach. That means best is you do HPV plus VIA. But if that is not given in the options, then the second best is HPV alone, and the third best is VIA alone. Is that clear to all of you? WHO does not recommend pap smear as a screening test, because if pap smear comes out to be positive, it should be followed by colposcopic biopsy. And if that also comes out to be positive, then you do treatment. कभी भी हम pap smear की report के basis पे treatment नहीं करते. You never do treatment based on pap smear report. Right? On the other hand, ACOG kya kehta tha? ACOG said that screening test which you should do is pap smear. And when should you start doing the screening test? At 21 years of age. You should repeat pap smear after every 3 years till a female becomes 30 years of age. When a female is 30 years of age, then along with pap smear, do HPV DNA testing, and you should repeat it after every 5 years till 65 years of age if in previous 10 years pap smear report was normal, or till 75 years of age if in previous 10 years pap smear was abnormal. Right? So these are again very, very important recommendations which have been given by WHO. You have to remember WHO protocol. You have to remember ACOG protocol. In your exams, they are going to ask, they are going to give you whether they are talking about ACOG protocol or whether they are talking about WHO protocol. If they ask you what is being done in India, we have to follow WHO's protocol. Clear? Okay, next very, very important topic, which is a recently overall screening test for cancer cervix. You cannot say overall there is a best screening test for cancer cervix. No, but just in case, suppose Solanki, if a question comes like this, you are going to answer as per this what I have given you. Overall, best is HPV plus VIA. If that is not given in the option, then second best is only HPV. If that is also not given, then third best is VIA. What is LEAP? LEAP and LLETZ are one and the same thing. LLETZ stands for large loop excision of transformation zone. LEEP stands for loop electroexcisional procedure. So suppose अगर आपके पास question आता है, what is the management of CIN2 or CIN3 in any age at any parity? अब वो कंफ्यूज करने की कोशिश करेंगे. दे विल से शी इज अ ग्रेविडा 3, ग्रेविडा 4, ग्रेविडा 5, 55 years female, right? What is the management of choice? चाहे वो ग्रेविडा 3 हो, 2, 4 हो, 5 हो, 1 हो, no matter what is the gravida, no matter what is the parity, management of CIN2 and CIN3 always is LEAP or LLETZ. You never do hysterectomy. Right? You are never going to do hysterectomy for CIN2 or CIN3. CIN1 का क्या management होता है? CIN1 का management is you have to wait and watch for 2 years. 2 years में most of the time CIN1 will automatically regress. But if CIN1 persists beyond 2 years, right? So if it persists for more than 2 years, then you go for cryosurgery or cryoablation. Clear? Your doubt cleared? Okay. Now coming to, as I was telling you, another very important cancer which recently has taken a lot of importance in all your exams, whether it is NEET, whether it is FMG exam, whether it is INI-SET, that is vulva cancer. You can expect one question from vulva cancer. So all are true about vulval cancer except option A, squamous cell keratinizing type is the most common variety. Option B, most common HPV associated with it is HPV 16. 60% cancers occur at clitoris. Option D, single most important prognostic factor is lymph node status. So I can see various answers again. B, there is a confusion between B and C to most of the students. So confusion chal raha hai. Some people saying B, most of you saying C. Chalo. Quickly let us Dr. Gurjar, this video is going to remain, but only those students who have the link will be able to watch it again. If you don't have the link to the session, you will not be able to watch it again, right? So, first important thing, most common variety for vulval cancer is squamous cell cancer, right? That's the most common type of vulval cancer. अब ये जो squamous cell cancer होता है, which is the most common variety, it has two types, warty type or keratinizing type. Keratinizing type is 60% cases, warty is 40% cases. Now, warty type is more common in young females between 55 to 60 years. Keratinizing is more common in older females, that is between 65 to 70 years. Warty is unifocal, keratinizing is multifocal. Warty has a good prognosis, keratinizing has a bad prognosis. Warty type of squamous cell cancer is associated with HPV. Now, this was a question in INI-SET this year, risk factors for vulval cancer. HPV, most common HPV associated with it is HPV 16, followed by HPV 33, right? Then smoking and VIN, right? Vulval intraepithelial neoplasia. Keratinizing is not associated with HPV. It is associated with lichen sclerosis, squamous cell hyperplasia, and mutation in gene P53. Most common age group for cancer vulva is postmenopausal age group. And as I told you, keratinizing is most common. That is why keratinizing ka age group most common hota hai. And that is more than 65 years of females may this is seen, vulval cancer. Most common symptom for vulval cancer is pruritus. For diagnosis of vulval cancer, Keys punch biopsy is done. Management of vulval cancer in stage 1 and stage 2 is surgery. In stage 3 and stage 4, it is chemoradiation, right? Now, please remember that the first lymph node which is involved in vulval cancer is superficial inguinal lymph node. And that is the sentinel lymph node for vulval cancer. इसके बाद the lymphatics will go into deep inguinal lymph nodes, that is femoral lymph nodes. That is why when we do surgery, we have to do surgery in terms of two things, surgery for the cancer and surgery for lymphatic spread, right? So कैंसर के लिए भी सर्जरी करनी है, जो लीजन है उसके लिए भी सर्जरी करनी है, and lymph nodes के लिए भी सर्जरी करनी है. Now, because the lymphatic drainage of vulva is first into inguinal and then into femoral, तो lymphatic spread के लिए you will have to do inguinofemoral lymph node dissection. Inguinofemoral lymph node dissection. Right? The only thing which you have to remember is that if tumor size is less than 2 centimeters and it is less than 1 millimeters deep, so if size of the tumor is less than 2 centimeters and it is less than 1 millimeters deep, so in that case, there is no need for inguinofemoral lymph node dissection. then there is no need for inguinofemoral lymph node dissection. But otherwise, you will have to do inguinofemoral lymph node dissection for vulva cancer. Now, as far as cancer is concerned, उसके लिए surgery कौन सी करेंगे? उसके लिए you can go for modified radical vulvectomy. They can be radical vulvectomy. So there are various types of surgeries like radical vulvectomy or modified radical vulvectomy. That is a little bit more detail. I don't expect them to ask you these things, but yes, as far as vulval cancer is concerned, small things you will be asked, and this much what I have told you, I feel this should be more than enough for you. You can also go for a radical local excision, right? So this much if you know on vulval cancer, this is more than enough for you people, right? Then the other thing is spread for vulval cancer. Spread for vulval cancer, it can be direct spread, lymphatic spread, or hematogenous spread. Prognostic factor, the single most important prognostic factor is lymph node involvement. And the second is depth of the lesion. As I told you, if the depth of the lesion is less than 1 millimeters, there is no lymph node involvement will be there, and that is why lymph node dissection is not needed, right? Clear to all of you? This much if you know, it's more than enough on vulval cancer. So squamous cell keratinizing type is the most common variety, yes. Most common HPV associated is HPV 16. Yes. 60% cancers occur at clitoris. No. What is the most common site for cancer, vulva cancer? Most common site for vulva cancer is labia majora and labia minora. In 60% cases, vulval cancer will involve labia majora and labia minora. Single most important prognostic factor is lymph node status. Yes. Clear to all of you? So please remember the age group for vulval cancer, types of vulval cancer, risk factors for vulval cancer, prognostic factor for vulval cancer, and some basic about the management of vulval cancer. If you remember this much, that's more than enough. Between majora and minora, if they ask you which is the most common site is majora, right? So now coming to the next question. Again, this is one of those questions where, these days they have started asking you about hormonal changes in various conditions. So this is something which you have to be very, very well aware of, right? So you have to match the clinical conditions with the correct hormonal profile. PCOS on one side, Asherman syndrome, Kalman syndrome, and Turner's syndrome. And on the other side, you have various hormonal profiles. Now, before all questions like these, just quickly remember some important basics. This over here is hypothalamus, right? Hypothalamus releases GnRH in a pulsatile manner. GnRH is going to act on anterior pituitary. From anterior pituitary, two hormones are released, FSH and LH, right? FSH and LH act on ovary, and from ovary estrogen is released, and from ovary progesterone is released, right? Estrogen and progesterone act on the uterus, from where bleeding happens. So all this cycle, this entire pathway, which is the hypothalamic pituitary ovarian axis, entire thing is needed for a female to menstruate properly, right? Now, there are certain problems which you have to remember related to hypothalamus. Hypothalamus की एक problem which you have to remember is Kalman syndrome. Kalman syndrome में there is hypothalamic failure. So there is going to be decreased GnRH. Because there is going to be decreased GnRH, there is going to be decreased LH, decreased FSH, decreased estrogen, right? Plus there is anosmia in Kalman syndrome, right? Now remember, estrogen has a negative feedback on FSH. Always estrogen will have a negative feedback on FSH. Progesterone in low concentrations has a positive feedback on LH. In high concentrations, it has a negative feedback on LH, right? Till here it is understood by all of you. So in Kalman syndrome, a female is going to have less LH, less FSH, less estrogen, and there is going to be anosmia. Now the main hormone which is needed for breast development is estrogen. That is why in Kalman syndrome, patient is going to come to you with complaint of primary amenorrhea because this pathway is not working properly. So there is going to be no menstruation, and she is going to come to you with complaint of absent breast development. In other words, delayed puberty. Right? So यहाँ पे अब देखो Kalman syndrome. For Kalman syndrome, what do you need? You need low LH, low FSH, low estradiol. Right? So this is the hormonal profile for Kalman syndrome. Right? Then comes the hormonal profile related to pituitary. What are the problems which can happen in pituitary which can alter the hormonal profile? So pituitary se related, there can be hyperprolactinemia. Hyperprolactinemia. When will there be hyperprolactinemia? If there is a prolactinoma, right? तो जब भी prolactinoma होगा या hyperprolactinemia होगा, prolactin has a negative feedback on GnRH. Again, because it has a negative feedback on GnRH, there will be decreased LH, there will be decreased FSH, and there will be decreased estrogen. Clear to all of you? This is going to happen in case of hyperprolactinemia. Hyperprolactinemia या prolactinoma में patient is again going to come to you with complaint of amenorrhea. And along with that, क्योंकि it is a prolactinoma, prolactin secreting tumor, there will be increased breast secretions, right? And because prolactin is a tumor of the pituitary, there is going to be headache and visual disturbances. Clear to all of you? Pituitary से related एक और चीज हो सकती है, and that is Sheehan syndrome. In Sheehan syndrome, there is necrosis of anterior pituitary gland. So all the hormones which are formed by anterior pituitary decrease. So there is decreased prolactin, there is decreased LH, decreased FSH, and obviously if LH and FSH are decreased, there will be decreased estrogen. Now, because prolactin is decreased, so this female is going to come to you with complaint of inability to breastfeed the baby. Inability to breastfeed the baby, right? And because of decreased LH and FSH, there is going to be amenorrhea. So if there is amenorrhea along with headache, visual disturbances, and increased breast secretions, it is prolactinoma. If it is amenorrhea along with inability to breastfeed the baby, then that is Sheehan syndrome. So these are the two things which you had to remember with respect to pituitary. With respect to ovary, अब ovary से related you have to remember two very important conditions. One is premature menopause. Premature menopause, which these days is called as POI. What is POI? Primary ovarian insufficiency. Primary ovarian insufficiency is a new name for premature menopause. So in case of premature menopause, again there will be decreased. Okay, so what is going to happen in case of premature menopause? There are no more follicles in the ovary. राइट इस पाथवे में प्रॉब्लम नहीं है. प्रॉब्लम ये है कि नाउ देर आर नो फॉलिकल्स इन द ओवरी विच कैन सिक्रीट ईस्ट्रोजन और प्रोजेस्ट्रॉन. राइट, द प्रॉब्लम इज नॉट इन pathway. Now, because there are no more follicles in the ovary, so in spite of this pathway working, there will be decreased estrogen, there will be decreased progesterone. Right, because there are no more follicles which can secrete estrogen and progesterone. Estrogen has a negative feedback on FSH. Now, because estrogen has a negative feedback on FSH and because estrogen is less, the negative feedback on FSH is gone. So there will be increased FSH. Progesterone has a negative feedback on LH. Now, because there is no progesterone, the negative feedback on LH is gone. So there will be increased LH. So this is the condition which you get in case of premature menopause. Decreased estrogen, decreased progesterone, increased LH, increased FSH. Please remember this, that in premature menopause, LH, FSH will be high, estrogen and progesterone will be less, right? Then in case of ovary, there can be another situation. That is PCOS, ovary से related PCOS. PCOS का I want all of you to remember this. In PCOS, there is an ovulation. Because of this an ovulation, there is decreased progesterone, number one. Number two, when we talk about estrogen, when you are talking about estrogen, estrogen can be normal or it can be increased. In obese females, it is increased. In thin females, it is normal, right? When it comes to LH and FSH, FSH is normal, LH is high. So this is something which I want all of you to remember for PCOS. In PCOS, FSH levels are normal, LH levels are high. Right? Both LH, FSH high nahi hote. It is FSH which is normal, LH which is high. Progesterone is decreased because of anovulation. Estrogen can be normal or estrogen could be increased. It is increased in obese females. Right? A बहुत typical thing which you get in PCOS is that androgen levels are high. They are high, but they are less than 200. Clear? All of you? Yes. LH is to FSH ratio becomes 3:1 in PCOS patients. Normally, this ratio is 1:1. In PCOS patients, this becomes 3:1. Right? Then comes your uterus-related problem, which is Asherman syndrome. Now, in Asherman syndrome, the entire pathway is normal. Problem is that there are uterine adhesions. So, in Asherman syndrome, there is no problem in the axis. The problem is that there are uterine adhesions. So, estrogen is normal, progesterone is normal, LH is normal, FSH is normal, right? The other thing which you have to remember related to ovary is there can be streak ovaries. Streak ovaries are seen in Turner's syndrome. Now you tell me, if there are streak ovaries, non-functioning ovaries, what is going to happen? Again, if there are non-functioning ovaries, what is going to happen? So there will be no follicles, and again, if there will be no follicles, estrogen will be less, progesterone will be less, So LH will be increased, FSH will be increased. Clear to all of you? Yes. The last thing which you have to remember, because all these hormones are something which trouble you a lot, what happens in pregnancy? In pregnancy, placenta is going to form estrogen, so estrogen will be high. Placenta and corpus luteum are going to form progesterone, so progesterone will be high. And because estrogen is high, so there will be negative feedback on FSH. So FSH will be decreased and LH will be decreased. So remember, जो condition menopause में होती है, उसका opposite happens in pregnancy, right? So if you remember these many hormonal conditions, all your questions related to hormones will be solved. So let us go back to this question and see PCOS. So what is going to happen in PCOS? In PCOS, as I told you, LH is high, FSH is normal, estrogen is normal, right? Asherman syndrome में everything normal, LH normal, FSH normal, estrogen normal. Turner syndrome में estrogen will be less, progesterone will be less, so LH and FSH will be high, right? So I hope all these hormones things are clear to you. This is very, very important. This is the recent way in which they have started asking questions. And I expect that in FMG also, they are going to ask questions based on hormonal profiles, right? Okay. Another very, very important topic. Now, please show me a thumbs up if till here it is clear to all of you. Quickly show me a thumbs up if this is clear to all of you. Now coming, I'm waiting for your thumbs ups. Okay, great. Now, match the vaginal discharge with the likely cause. Vaginitis is again a very, very important topic for your upcoming FMG exams. So you have to match the vaginal discharge with the likely cause. So Candida mein, what is the kind of discharge which you get? Maddie, I am not going to repeat it again, beta. What you can do is once this session is come over, you can come back to this, watch this video again at a slower speed and you will understand, right? Okay. So match the vaginal discharge with the likely cause. So over here, just a few very, very important things which I want to tell you about vaginal discharges. I'm sure this topic you are well versed with, but still quickly let's do. Trichomonas mein, whenever you are going to get a patient with trichomonas, she's going to come to you with complaint of frothy, yellowish colored discharge. The pH of the discharge will be more than 4.5. Pruritus will be present. Dysuria will be present. So there will be pain during micturition and you are going to get red vagina like strawberry. So that is strawberry vagina. Whenever you get a patient of Candida, the patient is going to come to you with curdy, white, scanty discharge. So in case of Candida, problem is not of discharge. Problem जो patient हमारे पास लेकर आती है, that is pruritus. She is more concerned about pruritus rather than discharge, right? And there is dysuria. The pH of the discharge, very important to remember, is that in Candida, the pH of the discharge is less than 4.5. In bacterial vaginosis, patient comes to you with a grayish white, yeah, off-white colored discharge with no pruritus, but it is foul smelling and whiff test is positive. Whiff test positive means when you add 10% potassium hydroxide, you get a fishy odor. Investigation of choice whenever a patient comes to you with vaginitis is saline microscopy. On saline microscopy, in case of bacterial vaginosis, you are going to get clue cells. Right now, in case of trichomonas, what is the drug of choice? In case of trichomonas, the drug of choice is metronidazole. It is a sexually transmitted disease, and that is why partner treatment should be done in trichomonas. In case of Candida, the drug of choice is fluconazole. But please remember, if your patient is pregnant, then in that case you have to give topical imidazoles like clotrimazole. In that case you don't give oral fluconazole. In that case you give topical clotrimazole, right? In case of candida, it can be a sexually transmitted disease, so only if your partner has symptoms, then partner treatment is necessary. Otherwise partner treatment is not necessary. Bacterial vaginosis is just a alteration in vaginal flora. It is not an STD. The drug of choice for bacterial vaginosis is metronidazole or clindamycin, right? And for bacterial vaginosis, you don't have to give any partner treatment. The typical thing about bacterial vaginosis is that there is no inflammation, so there is no pruritus. Clear? Another very important thing which at this point of time I want you to revise is that there is something which is called as syndromic management of vaginal discharge. For syndromic management of vaginal discharge, the kit which you have to give is kit number 2, which is a green kit. And in this green kit, there is 1 tablet of fluconazole and 1 tablet of secnidazole. There is no metronidazole, there is secnidazole. So 1 tablet of fluconazole 150 milligrams and 1 tablet of secnidazole 2 grams. Now, whenever you are doing syndromic management of vaginal discharge, partner treatment is not given, right? What was whiff test was that when you add 10% potassium hydroxide to the discharge, you get a foul or a fishy odor, right? And whiff test is positive in case of bacterial vaginosis. Now, you should also remember syndromic management of PID. According to NACO guidelines, our National AIDS Control Organization guidelines, for PID, we have to do least investigations and give the patient treatment. So whenever a patient comes to me with PID, with suspected case of PID, I'm going to take her history. Most commonly, she's going to give me history of lower abdominal pain, or she may give me history of vaginal discharge, abnormal uterine bleeding, urinary symptoms, or secondary dysmenorrhea. But mostly there is going to be lower abdominal pain. So when I'm going to do examination, if I get uterine tenderness or adnexal tenderness or cervical movement tenderness. Now, whenever you get cervical movement tenderness, you have to think about 2 things. Either it can be a case of ectopic pregnancy or it can be a case of PID. So do a urine pregnancy test. If urine pregnancy test is positive, probably you are dealing with ectopic pregnancy. If urine pregnancy test is negative, then you have to go for PID as the diagnosis. So the syndromic diagnosis jo hamari banti hai, that is lower abdominal pain syndrome. So if your patient has lower abdominal pain and along with this, any of these, along with lower abdominal pain, any of these, uterine tenderness, adnexal tenderness, or cervical movement tenderness, then you make a diagnosis of lower abdominal pain syndrome. And for managing lower abdominal pain syndrome, you give yellow kit or kit number 6 to the female, right? This kit number 6 has got doxycycline, cefixime, and metronidazole. Now, whenever you make a syndromic diagnosis of lower abdominal pain syndrome, you don't only have to give a kit to the partner, to the female, that which is kit number 6, yellow kit. You also have to give treatment to the partner, and to the partner you are going to give kit number 1, which is gray kit, which has got azithromycin and cefixime. If they ask you in which other conditions do you use gray kit is used for managing urethritis, cervicitis, anorectal discharge, and scrotal pain syndrome. So partner treatment of PID में use करते हैं, along with that urethritis में भी use करते हैं, cervicitis में use करते हैं, anorectal discharge में, and scrotal pain syndrome में we use kit number 1, which is gray kit. So in gynae, you have to remember 3 kits: yellow kit, green kit, and gray kit. Or the rest of the 3 kits you have to remember for dermatology, and you will read it in your dermatology lectures, right? So you have over here, I told you kit number 2, that is green kit, is for vaginal discharge. Kit number 3, kit number 6, that is yellow kit, which is for your managing a female patient with PID. And kit number 1, that is gray kit, that is for partner treatment of PID. Along with that, it is also used for managing urethritis, cervicitis, scrotal pain syndrome, and anorectal discharge. Clear? Very, very important are these kits. So over here, it's written कैंडिडा में कैसा डिस्चार्ज मिलेगा? कैंडिडा में you are going to get a thick, scanty, non-foul smelling discharge with itching. Right? In bacterial vaginosis, the discharge will be foul smelling but without any itching. Right? In trichomonas, you are going to get yellow with itching and dysuria. Now coming to physiological discharge. Again, before I go to the other question, I'll come back to this question. I am going to the other question, and that is one question that is characteristic of physiological discharge are. You have to tell me what are the correct answers here. 1 is scanty, 2 associated with dysuria, 3 non-pruritus, 4 foul smelling. So tell me which options correctly describe a physiological discharge. A, B, C, or D. A is 1 and 3, B is 1 and 4, C is 3 and 4, D is 2 and 4. Tell me. Okay, so I've started getting answers. Most of you are saying it's option A. Right. So remember, physiological discharge, when it comes to color, it will be colorless. Right? तो options में या तो colorless लिखा होगा या white लिखा होगा. Right? Number 1. Number 2, when it comes to odor, it will be non-foul smelling. Right? Number 3, when it comes to pruritus, there is no itching. So just now we saw that bacterial vaginosis discharge was also white in color and it was not associated with itching, but bacterial vaginosis ka discharge was foul smelling. Over here, this is like bacterial vaginosis, but it is non-foul smelling. Then comes quantity. A quantity depends upon the time at which physiological discharge is happening. If this is happening in first half of the cycle, then it will be profuse under the effect of estrogen. And if it is happening in second half of the cycle, it will be scanty. तो फिजियोलॉजिकल डिस्चार्ज के आगे स्कैंटी भी आ सकता है, फिजियोलॉजिकल डिस्चार्ज के आगे प्रोफ्यूज भी आ सकता है. Right? Physiological discharge could be profuse, it could be scanty, depending upon the time at which it is happening. But the two very important characteristics of physiological discharge are that it is not associated with any itching and it is non-foul smelling. So it can be scanty, yes. Is it associated with dysuria? No. Is there any pruritus? Yes, there is no pruritus. Is it foul smelling? No. Right? So over here, 1 and 3 are the correct options. That is option A is the right answer. Clear to all of you? Okay. So same thing you got in this question also. Physiological discharge, non-foul smelling, thin, copious. Now that depends upon the time at which it is happening. If it is happening in first half of the cycle, it will be profuse, right? It will be thin. It will be watery, right? It will be elastic. It can be stretched. But if it is happening in second half of the cycle, it will be scanty. It will be thick. Right? It will be non-elastic. So that all depends upon the time of the cycle in which it is happening. Right? I'm sure all of you know the phenomena of spin barkite. What is spin barkite? Spin barkite is stretching of cervical mucus. And when does this happen? This happens in first half of the cycle under the effect of estrogen. Right? Okay. Next question. Next question is a very oftenly repeated question, and that is composition of mala N. Please remember, Mala N and Mala D, they have the same composition. They have 35 micrograms of estrogen, that is ethinyl estradiol, and 0.15 mg of levonorgestrel. So 35 micrograms of ethinyl estradiol and 0.15 mg of levonorgestrel. What is the difference? The difference is Mala N is no cost. It is distributed free of cost by Government of India. Mala D is available at a subsidized rate, right? Another very important thing which I want to tell you is, जब भी हम OCPs का oral combined pills का classification करते हैं, and whenever we say first generation pill, second generation pill, third generation pills, the generation is told in terms of progesterone, right? So when we say first generation pills, it means that the pill has got first generation progesterone. Second generation pills, second generation progesterone. Now, I don't want you to remember all the generations. What I want you to remember is what are the progesterone which come in third generation and which are the progesterones which come in fourth generation. Is pe questions are asked. Third generation progesterones are gestodine, desogestrel, etonorgestrel, and norgestimate. Why am I saying that you need to remember third generation progesterones? This is because progesterone have androgen like action, right? And all of us know कि PCOS के patient में, if a PCOS patient is having irregular cycles, we will give OCPs. For hirsutism, we give OCPs. And I am saying that progesterone has androgen-like action. So if progesterone has androgen-like action, we shouldn't be giving it to a patient with PCOS. Now, the thing is that as the generation increases in progesterone, the androgenic side effects keep on decreasing. This is the reason why third generation progesterone have least androgenic side effects and fourth generation are anti-androgenic. तो जब भी पीसीओएस का पेशेंट आएगा एंड हमें उसे ओरल कंबाइंड पिल्स प्रिस्क्राइब करनी है, I'm going to choose from third generation progesterone or fourth generation progesterone. And that is why questions are asked to you. They can ask you that a patient of PCOS was having hirsutism. What is the drug of choice? So all of you know that the drug of choice for hirsutism is OCPs. They can go a step further. Once in your exams, OCPs में भी उन्होंने दो ऑप्शन लिख दिए थे. One was ethinyl estradiol plus levonorgestrel. Other was ethinyl estradiol plus desogestrel. And that is where this knowledge comes in handy to you. कि जब भी PCOS का patient आएगा, I am going to give OCP, but I have to choose an OCP where progesterone belongs to third generation or fourth generation. So gestodine, desogestrel, etonorgestrel, and norgestimate are third generation progesterones, and criproterone acetate and drospirenone are fourth generation progesterones. Now, second classification of OCPs is based on estrogen content. अगर estrogen का amount is more than equal to 50 micrograms, we call it as high dose pills. These days we do not use high dose pills. Low dose pills का मतलब है कि estrogen is less than 50 micrograms. That is, it is generally between 20 to 35 micrograms. Very low dose means less than 20 micrograms. The lowest possible dose of estrogen, which can be seen in oral combined pills, is 10 micrograms. And this is a new pill which has come by the name of Lowestrin. Lowestrin में जो estrogen का component होता है, that is less than 10 micrograms or less 10 micrograms. Sorry, not less than 10. Please don't remember that. It's 10 micrograms. It has the lowest possible estrogen content, and that is 10 micrograms, right? So low dose pills means less than 50. Very low dose means less than 20. Lowest possible is 10 micrograms. Clear to all of you? Another very important question which they ask you on OCPs is, what is the main mechanism of action of OCPs? Please remember, the main mechanism of action of OCPs is it brings about an ovulation, right? That is the main mechanism of action of OCPs. OCPs pay. Another question which they ask you is, which of the following are absolute contraindication of OCPs? Very, very important question. Absolute contraindications of OCPs, as far as contraceptives are concerned, I don't want you to rely on the information which is given in PARC. PARC में updated नहीं है. If you are a Maru subscriber, you are going to follow what I have taught you in your lectures. If you are not a Maru subscriber, this is the list which I'm going to give you. You are going to remember this list of absolute contraindications for OCPs, right? So let me first tell you the list and then I'll come back to this question. So for remembering the absolute contraindications of OCPs, remember the mnemonic: banks have various schemes to provide home loans during May, where B stands for a known or suspected case of breast cancer. H stands for uncontrolled severe hypertension. So remember, mild hypertension is not an absolute contraindication. Uncontrolled severe hypertension, where systolic BP is more than equal to 160, diastolic more than equal to 100, is an absolute contraindication, right? Then V stands for undiagnosed vaginal bleeding. S stands for smoker more than 35 years of age. So अगर कोई female की age 35 है and she's not smoking, then that's not an absolute contraindication for OCPs, right? Only if she's a smoker and her age is more than 35, then that's an absolute contraindication for OCPs. T stands for a known or suspected case of thromboembolism, or if there is family history of idiopathic thromboembolism, or if there is history of coronary vascular accidents, MI, or conditions predisposing to it, right? Then P stands for pregnancy, or if there is history of peripartum cardiomyopathy. H stands for severe hypercholesteremia or hypertriglyceridemia. L stands for impaired liver function at present. Past history of liver disease is not a contraindication. Presently agar liver disease hai ya liver cancer hai, that's a contraindication for OCPs. D stands for diabetes with vasculopathy. Simple plain diabetes is not a contraindication, right? But yes, diabetes with vasculopathy is an absolute contraindication. Similarly, plain simple migraine is not a contraindication. Migraine with aura or migraine with focal neurological deficit is an absolute contraindication. Clear to all of you? Yes? Okay. So with this background, tell me, which of the following are absolute contraindications of combined oral pills? Number one, arterial or venous thrombosis history. Yes or no? Quickly type in your chat box. Yes or no? Arterial or venous thrombosis history is a contraindication. Yes. Severe hypertension. Yes. Gestational trophoblastic neoplasias. No, that's not a contraindication. Diabetes with vascular complications. Yes, that is a complication. So 1, 2 and 4, that means option B is the correct answer for this question. Clear to all of you? Yes? Okay. Remember, contraceptives may one more thing is very, very important for you. One is IUCD, copper IUCD, don't forget to read it. Mirena is very important, and emergency contraception is very, very important, right? Acha. Another absolute contraindication for OCPs is in a breastfeeding female and in a female who's less than 21 days postpartum, irrespective of whether she's breastfeeding or not. Agar female is less than 21 days postpartum, then you are not going to give OCPs. Now, suppose I say she's not breastfeeding. So there is a female who's not breastfeeding. Can non-breastfeeding females can you give OCPs? You can give OCPs, but after 21 days. Why not before 21 days? Because OCPs have got estrogen plus progesterone. Estrogen क्या करते हैं? Estrogen increase करते हैं clotting factors को. So estrogen increase the clotting factors. Pregnancy in itself is a hypercoagulable state. That is why even if the female is not breastfeeding, till 21 days after delivery, I am not going to give OCPs. Clear to all of you? Right. So these were important points, important topics which I wanted to tell you in gynae. Now coming to a few important questions in OBS. All are true about abruptio placenta except abruptio placenta, that is antepartum hemorrhage, is a very, very important topic for all of you, right? So option A, folic acid deficiency is a risk factor. Option B, on per abdominal examination, uterus is rigid and tender and patient presents per vaginally with bleeding. Option C, per vaginal examination is contraindicated. Option D, termination of pregnancy is the management in case of abruptio. So what is the answer? I've started getting answers from all of you. You people don't have many confusions in this question. There is no confusion here. All of you are very clear. अब जैसी मैंने कहा, all of you are very clear. गलत आंसर आना स्टार्ट हो गए. Now you have started giving me wrong answers. The correct answer is option C. Right? Option B is right. Please correct answer over here. Answer is option C. So remember, folic acid deficiency is a risk factor. Yes, folic acid deficiency is a risk factor for abruptio placenta. Now, all those who are Marrow subscribers or who have attended my live teaching, you know that I make this lady everywhere for remembering risk factors for abruptio placenta. Right? So, we have a female over here. There is increased maternal age of this female and increased maternal parity. Right? She is smoking. So, there's cigarette smoking is a risk factor. Cocaine abuse is a risk factor. Now, bachcho, risk factors generally, they never ask you per se, right? But there are 4 topics जिसमें risk factors पे direct questions आते हैं. Placenta previa के risk factors पे direct question आएगा. In abruptio, you are going to get direct question on risk factors. In PIH, you are going to get direct question on risk factors, and in PPH. In charo ke, in all these 4 conditions, risk factors have to be on your fingertips, right? Other than that, risk factors pe questions nahi aate hain. Generally, you get questions related to risk factors from these 4 topics, right? So now this female has folic acid deficiency, because of which she has killosis around her lips. So folic acid deficiency. Then in blood vessels, there is high BP, that is PIH, and thrombophilia. A risk factor related to abdomen is abdominal trauma. Risk factor related to uterus is twin pregnancy, polyhydramnios, premature rupture of membranes, and fibroid uterus. Right? So twins में polyhydramnios होता है. Polyhydramnios से membranes can rupture. Now when membranes are going to rupture, the entire amniotic fluid is going to come out suddenly. So the size of the uterus will shrink suddenly. And jump size of the uterus will suddenly shrink. So the placenta which was attached to the uterus will get detached. Right? So these are risk factors related to abruptio. So yes, folic acid deficiency is a risk factor. Right? On per abdominal examination, in case of abruptio, uterus is rigid tender, and patient presents with pervaginal bleeding. That is absolutely right. In case of placenta previa, uterus is soft. In placenta previa, uterus is soft and relaxed. Whereas, and there is no pain in abdomen. Whereas in case of abruptio, patient is going to present to you with pain in abdomen and with bleeding beyond 28 weeks of pregnancy. Is pervaginal examination contraindicated? No. In case of abruptio, pervaginal examination is not contraindicated. It is in case of placenta previa that pervaginal examination is contraindicated. In case of abruptio, once you have ruled out placenta previa, you have to do a pervaginal examination. Why am I saying you have to do? This is because abruptio ke patients mein, when the placenta separates from the uterus, thromboplastin is released, right? एंड ये जो थ्रोम्बोप्लास्टिन रिलीज होता है ये पेशेंट को लेबर में ले जाता है एंड बिकॉज ये पेशेंट को लेबर में ले जाता है आई नीड टू सी हाउ मच इज द सर्विक्स डायलेटेड राइट so in case of abruptio you have to do a pervaginal examination but it should be done after ruling out placenta previa यही थ्रोम्बोप्लास्टिन है जो यूट्रस को टेंस्ड बनाता है एंड टेंडर बनाता है यही थ्रोम्बोप्लास्टिन है विच लीड्स टू डीआईसी एज अ कॉम्प्लिकेशन so DIC is a complication of abruptio. DIC is not a complication of placenta previa. Then termination of pregnancy is a management in case of abruptio. Yes. In case of abruptio, because placenta has started separating, so the best management is termination of pregnancy. Although I am now going to share with you the updated management of abruptio. This is the updated management. Iske baad, just now I'm going to share with you updated management. I want all of you to keep the updated management of abruptio also in your mind. So answer to this question is option C, right? So over here, suppose आपके पास question ऐसे आता है कि there is a G2P1 pregnant female who has come to you at 34 weeks. Her BP is 150 by 110. There is pain in abdomen and bleeding PV and they ask you what is the next step. तो सबसे पहले तो I want all of you to see that bleeding is happening beyond 28 weeks and जब भी bleeding होती है beyond 28 weeks, whenever bleeding is happening at more than equal to 28 weeks, you have to think about abruptio or you have to think about placenta previa or in rare circumstances, there can be vasa previa, right? Then in case of abruptio, you are going to get history of trauma या PIH. अगर predisposing factor में trauma या PIH दिया है, it means it is going more in favor of abruptio. In placenta previa and vasa previa ऐसी कोई history नहीं मिलती, right? Then suppose your question says that there was bleeding which happened and then it stopped and 2 दिन बाद again patient started bleeding. So there is recurrent bleeding. So whenever you get history of recurrent bleeding in the question, that 2 days back patient had bleeding, then it stopped and then it started again, then think about placenta previa. Then don't think about abruptio, don't think about vasa previa. Then if pain in abdomen is given, whenever pain in abdomen is given, you have to think about abruptio. You don't have to think about placenta previa or vasa previa. Then on per-abdominal examination, in case of abruptio, uterus will be tensed, it will be tender, it will be rigid. Height of the uterus is more than the period of gestation and most of the time fetal heart sounds में या तो distress मिलेगा या death मिलेगा, right? This is because of the concealed variety of abruptio. Whereas in case of placenta previa, uterus will be relaxed, uterus will be non-tender, uterus will be soft, height of the uterus will be equal to period of gestation, and fetal heart sounds will be normal. वासा प्रिविया हम कब सस्पेक्ट करेंगे? वासा प्रिविया आप तब सस्पेक्ट करोगे in your questions if your question says that ARM was done, आर्टिफिशियल रप्चर ऑफ मेम्ब्रेन्स हुआ था, या मेम्ब्रेन्स रप्चर हुई ऑटोमेटिकली एंड सडनली there is the fetal heart rate drops down and there is bleeding. तो मेम्ब्रेन रप्चर के बाद fetal heart rate dip कर गया and bleeding हुई, that means you are dealing with vasa previa. Membrane rupture के बाद केवल fetal heart rate drop किया, that means you are dealing with cord prolapse, right? So whenever your question says that there is bleeding plus there is fetal distress which happened immediately after membrane rupture, that means vasa previa. Clear to all of you? Yes? Okay. Now, in this question, clear cut, they are talking about abruptio. And whenever they are talking about abruptio and they ask you the next step, then see कि क्या question में have they given you any emergency condition like fetal distress, DIC, या question में दिया है कि maternal vitals are unstable. In that case, your next step becomes immediate cesarean section, right? या क्वेश्चन में दिया है कि एब्रप्शियो है एंड एब्रप्शियो के अंदर फीटल डेथ हैज हैपेंड. Now, if fetal death has happened and vitals of the patient are unstable, the next step is immediate cesarean section. If fetal death has happened but vitals of the patient are stable, then the next step is induction of labor. Now, suppose abruptio का scenario है and nothing, no emergency situation is given. मदर के वाइटल्स भी स्टेबल हैं, फीटल हार्ट साउंड्स नॉर्मल है, नो इमरजेंसी कंडीशन. देन लुक एट द जेस्टेशनल एज. If gestational age is more than 34 weeks, your answer will be induction of labor. Don't say cesarean section, induction of labor. And if it is less than 34 weeks, expectant management. Clear? So in case of abruptio, overall, thumb rule is कि induction of labor या termination of pregnancy should be done. But then induction of labor करेंगे कि cesarean section करेंगे, that depends upon what further information is given to you in the question. One very important thing which I want all of you to note, that if you are a Marrow subscriber and if you have read edition 5, in edition 5 I told you that if there is a patient with abruptio and DIC, then I told you first correct DIC followed by vaginal delivery. कि कभी भी DIC के patient में cesarean नहीं करते. Now the new recommendations have come, and that is if a patient has DIC and there is abruptio, then you have to correct DIC and do cesarean section. Now they say in a patient of DIC, you don't go for vaginal delivery if abruptio is present. Is this point clear to all of you? Note this point because I'm sure some of you are not watching edition 6 revision videos, and that is why you are not well versed with these things which are happening, which these updates which I have given in edition 6. Now please remember, expectant management of placenta previa का नाम है McCafe and Johnson regime. Abruptio के expectant management का there is no name. Rather, expectant management is something new which has come in abruptio. Right? Till now, we said that we don't do expectant management in abruptio. So, McCafe and Johnson regime, which all of you are writing in the comment box, that is expectant management for placenta previa and not for abruptio. Clear to all of you? Yes? Okay. Coming to a next question. So, a 34-year-old G2P1 at 31 weeks of gestation presents to the labor and delivery with complaints of vaginal bleeding which happened earlier in the day and then resolved on its own. As I told you, इस type की जो typical history होती है that bleeding was present and now it has resolved. This is a typical history which you get in patients of placenta previa, right? So she is 31 weeks coming to you with bleeding, which stopped that day. There is no leakage of fluid, no uterine contractions. She reports good fetal movements. In her last pregnancy, she had a cesarean section. She denies any medical problems. Her vital signs are normal. Electronic external fetal monitoring shows fetal heart rate is reactive, no uterine contractions. Which of the following is the next step in management? So, this patient is coming to you with antepartum hemorrhage, right? And uh, most probably she's a case of placenta previa, but then I have to confirm that she's a case of placenta previa. And in order to confirm that she's a case of placenta previa, what am I going to do? I am going to do ultrasound. Please remember, per vaginal and per speculum examination is contraindicated. Now, whoever has written option A, send her home since her bleeding has resolved. Please remember, placenta previa mein there is something called as warning hemorrhage, which means कि placenta previa के patient में initially there is less bleeding and this is followed later on by excessive bleeding. So without confirming that she's a case of placenta previa, without doing the needful expectant management, I am not going to send her back home, right? So option A is wrong, right? So, whenever a patient comes to you with recurrent bleeding, you always have to think about placenta previa. In placenta previa, per vaginal and per speculum examination are contraindicated. So, the next step is ultrasound. Ultrasound में कौन सा ultrasound? जो screening ultrasound होता है, that is abdominal ultrasound. Or in abdominal ultrasound, I will see that the placenta is located in the upper segment or in the lower segment. If placenta is located in upper segment, it means it is abruptio. If it is in lower segment, that means it's placenta previa. Now, once I know that it is placenta previa, then the investigation of choice is TVS, transvaginal sonography. Remember, in placenta previa, per vaginal examination is contraindicated, but investigation of choice is TVS. Why is TVS investigation of choice? This is because of the new classification. I don't know whether you all are well versed with the new classification or not. Nowadays, there is no type 1, type 2, type 3, type 4 placenta previa. Nowadays, we classify placenta previa as low-lying placenta previa, as low-lying placenta and placenta previa. Low-lying placenta का मतलब है a placenta which reaches within 2 centimeters of the internal os, but it does not touch or doesn't cover the internal os, right? So a placenta which reaches within 2 centimeters of the internal os, but it doesn't touch or cover the internal os is low-lying placenta previa. And that's a low-lying placenta. Placenta previa is a placenta which is at the level of internal os or it covers it. A placenta which touches up till the level of internal os or covers it is placenta previa, right? So, in case of placenta previa, the mode of delivery is vaginal, is a cesarean section, and mostly you go for lower segment cesarean section. Rarely you may have to do a classical cesarean section. Remember, classical cesarean section का मतलब है you are giving incision in the upper segment. These days we do not do classical cesarean section unless and until you cannot approach the lower segment, right? So in case of placenta previa, because the placenta is in lower segment, and if you feel that if I'm going to do a lower segment cesarean section, patient is going to have a lot of bleeding, in that case you may do a classical cesarean section, right? Or if there is cancer cervix, then you do a classical cesarean section. Or if you are doing a perimortem cesarean section. Perimortem cesarean section means that patient is about to die and you are doing a cesarean section, then you are going to go for classical cesarean section. Clear to all of you? Otherwise, we go for lower segment cesarean section, that is LSCS. In case of placenta previa, you are not going to try for vaginal delivery. In case of placenta previa, always cesarean section. Clear? Then, Next question, which is a repeat question from your previous year questions. Acha, Jayesh, beta, this is wrong what you are writing. Phenensteel incision is the incision which you give on skin. तो जब भी हम सिजेरियन करते हैं हमें स्किन पे भी इंसिशन देना होता है और हमें यूट्रस पे भी इंसिशन देना होता है, राइट? स्किन पे जो हम इंसिशन देते हैं, जो हम लो ट्रांसवर्स इंसिशन देते हैं, दैट इज अ फेनेंस्टील इंसिशन, राइट? Whereas uterus पे जब हम incision देते हैं, you can give an incision in the upper segment. This is called as classical cesarean section. Or you can give a transverse incision in the lower segment. This is called as LSCS. As इस incision का नाम होता है Munroker incision. So Kerr incision. Kerr incision. Right? This is not a Phenensteel incision. Phenensteel incision is the incision which you give on skin. Okay. Now, an intern conducts such as, so I've started getting answers. So D, B, okay, let me see what it is. An intern conducts a delivery. Immediately after delivery, mother experiences breathlessness, hypotension, tachycardia, collapse. Per vaginal examination is normal and there is no excessive blood loss. Most probable diagnosis is a postpartum collapse pe a lot of questions are being asked. And whenever you get a question on postpartum collapse, postpartum shock, you have to think about three things. Either it is a case of PPH, or it's a case of uterine inversion, or it's a case of amniotic fluid embolism. Now, PPH may, primary PPH will occur within 24 hours of delivery. Uterine inversion, जो acute uterine inversions होते हैं, they occur within 24 hours of delivery. And amniotic fluid embolism, it occurs at the time of labor or within 30 minutes of delivery. In PPH, patient is going to present to you with excessive bleeding. So excessive bleeding hogi and बाद में patient is going to go into shock, right? In case of uterine inversion, you can get excessive bleeding or you can get less bleeding and patient will go into shock. Why? Because in case of uterine inversion, shock जो होता है, initially it is neurogenic shock. Initially it's a neurogenic shock. So initially bleeding less hoti hai, right? And later on there is hemorrhagic shock. Later on bleeding ज़्यादा होती है. So if your question ever says that patient goes into immediate shock after delivery, whenever your question says patient goes into immediate shock, the word immediate means they are trying to point towards uterine inversion. They may say that bleeding was less, they may say bleeding was more. Generally, they are going to tell you bleeding is less because they want you to point towards neurogenic shock, right? In case of amniotic fluid embolism, in amniotic fluid embolism, there are two phases. In the first phase, patient has cardiac and respiratory failure. ये respiratory and cardiac failure is the most important thing or the most important clue for diagnosing amniotic fluid embolism. जब भी question में ये दिया हो कि patient को breathlessness हुई and patient went into shock. This breathlessness you are never going to see in PPH, you are never going to see in uterine inversion. Breathlessness के साथ अगर shock मिल रहा है, it means it is amniotic fluid embolism. Now, if your patient survives this phase, then she is going to go into the second phase and then she is going to have TIC. So initially patient को less bleeding होगी, patient को breathlessness होगी and she will go into shock. Later on there is going to be excessive bleeding, right? On per abdominal examination, in case of PPH, the tone of the uterus will be absent, right? So uterus might not be palpable at all. In case of uterine inversion, you are going to get a cup-like depression below the umbilicus. In amniotic fluid embolism, per abdominal, normal, no Everything will be normal. Tone of the uterus will be normal. सब कुछ normal होगा on per abdominal examination. In case of PPH on per vaginal examination, excessive bleeding will be present. In case of uterine inversion, when you are going to do a per vaginal examination, you are going to feel a rounded mass filling the vagina, plus there will be bleeding. In case of amniotic fluid embolism, everything will be normal on per vaginal examination, right? So with this, let us see. Your patient had breathlessness. जैसे ही ये word पढ़ो breathlessness, and hypotension, tachycardia, and collapse, it means they are talking about amniotic fluid embolism. Per vaginal examination is normal and there is no excessive blood loss. This means they are talking about amniotic fluid embolism. अगर ये PPH होता तो ये no excessive blood loss na diya hota. Right? In case of PPH, patient will go into shock only after excessive blood loss. If it would have been uterine inversion on per vaginal examination, you would have felt a cup like, you would have felt a rounded mass in the vagina. In case of DIC, there would have been excessive blood loss. This means that this is a case of amniotic fluid embolism, the first phase of amniotic fluid embolism. Clear to all of you? Yes? Okay. Next question, again related to an obstetrical emergency. Obstetrical emergencies are very, very important. You get a lot of questions on obstetrical emergencies. A G2P1 undergoing delivery presents with full dilatation of the cervix. Head of the fetus is at +1 station and membranes are ruptured. After 15 minutes, the head of the baby delivers, but shoulders fail to deliver. The resident on duty gives episiotomy and instructs the nurse to call for help. Next step in management is. So, what is the next step in management? Tell me what's the next step? Okay, so I'm getting a difference of opinion here. Some of you are saying A, some of you are saying B. Shoulder dystocia ka management, it has to be remembered in a stepwise manner, right? You have to remember it in this order. If you are a Marrow subscriber, you know this already, the acronym HELPER, where H stands for call for help, E stands for give episiotomy. तो help हो गया, episiotomy हो गया. Then comes L. L stands for legs maneuver, that is Mac-Roberts maneuver. What do you do in Mac-Roberts maneuver? You flex the legs of the patient. Rather, you hyperflex the legs of the patient. Right? And this is what is Mac-Roberts maneuver. अगर Mac-Roberts maneuver fail होता है, then you go to the next step, and that is you are going to give suprapubic pressure and then again perform Mac-Roberts maneuver. So सबसे पहले you perform Mac-Roberts maneuver without suprapubic pressure, and if that fails, then you go to P, that is you give suprapubic pressure and then perform Mac-Roberts maneuver. If that also fails, then you go for E, that is enter and rotate. Enter and rotate me, you are going to take your hands inside and rotate the shoulders. Simply remember there are two maneuvers which are done by this way: Wood's corkscrew maneuver and Rubin 2 maneuver. If that also fails, then R, that is remove the posterior arm forcefully. Baby ke posterior arm ko forcefully niche pull karo and then try to deliver the shoulders. If that also fails, then roll the baby, not the baby. Roll the mother to all four limbs. So tell the mother to lie on her all four limbs, which is called as Gaskin maneuver or all four maneuver, and then try to deliver. And if that also fails, then you go to Zavanelli's maneuver, which is you push the baby back and do a cesarean section. Push the head of the baby back into the uterus, followed by a cesarean section. So this HELPERR, this is the acronym, and these are the steps in which you have to do in this order. Every maneuver has to be tried only for 30 seconds. 30 seconds में अगर shoulder deliver नहीं हो रहे हैं, go to the next maneuver, right? Another very important thing is about Mac-Roberts maneuver. That Mac-Roberts maneuver, when you are performing, which nerve can get injured? It is lateral cutaneous nerve of the thigh. Please remember that the most common complication of shoulder dystocia, the most common fetal complication of shoulder dystocia is Erb's palsy. In Erb's palsy, if they are going to do anatomy and OBGY integration, they are going to ask you which nerve roots are involved. C5 and C6 nerve roots are involved. What is the most common maternal complication of shoulder dystocia? PPH. Agar baby dead hai, then you can do cledotomy. What is cledotomy? You can fracture the clavicle and deliver the baby. There is no role of symphysiotomy. Symphysiotomy means you are dividing the pubic symphysis of the mother. So remember this HELPERR and your questions on shoulder dystocia will be solved. Excellent, Pavitra. In Erb's palsy, you get a policeman tip deformity. That's very good, right? You get a policeman tips deformity. C5, C6 nerve roots are involved. So over here, the next step will be you have to flex the legs of the patient. Suprapubic pressure uske baad ka step hai. Fundal pressure is contraindicated in patients of shoulder dystocia. You never do fundal pressure, right? And cesarean section, that is Zavanelli's maneuver, that's the last step. That's always the last step in management of shoulder dystocia. So in your question, whenever there is a choice between suprapubic pressure and flexing the leg of the patient, you are going to choose flexing the leg of the patient first, followed by suprapubic pressure. Clear? Next very important question. All of the following are recommended by WHO for management of second stage of labor except a very, very oftenly repeated question. See, over here, दोनों चीजें याद रखो. थर्ड स्टेज का मैनेजमेंट बहुत इंपॉर्टेंट है. एक्टिव मैनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर बहुत इंपॉर्टेंट है. एंड सेकेंड स्टेज का मैनेजमेंट इज वेरी इंपॉर्टेंट. Right? I'm sure by now all of you on your tips you remember third stage ka management. What are the steps in active management of third stage of labor? The first step, the first thing is you have to give injection uterotonic to the mother after the delivery of the baby or after the delivery of the shoulder of the baby. The second step is you have to go for delayed cord clamping. Third step is you have to deliver the placenta by controlled cord traction. And the fourth step is intermittent assessment of uterine tone. Intermittent assessment of uterine tone से पहले क्या था? Earlier it was uterine massage. These days it is intermittent assessment of uterine tone, which is not included in active management of third stage of labor, early cord clamping. Early cord clamping is never included in active management of third stage of labor. Now comes management of second stage of labor. Second stage of labor में WHO recommends कि there can be position. क्या position होनी चाहिए? Any position according to the patient, right? Any position of her choice. Please remember, in the second stage of labor, fundal pressure and routine episiotomy are not recommended by WHO. WHO says when you are delivering the baby, then you are not going to give fundal pressure, and while delivery of the fetal head, in every patient, you are not going to give episiotomy. Episiotomy has to be given only if it is indicated. But what are the other things which it tells are recommended? So recommendations are perineal support. When you are delivering the head of the baby, your one hand should be supporting the perineum. Number two, you can put a warm compress at the perineum, or you can do a perineal massage. Why are you doing all this? Because all this is going to relax the perineal muscles. And जब perineal muscles relax हो जाएंगे, तो जब baby का head deliver होगा, तो chances of perineal tear will be less. Right? Then WHO says that initially you should flex the head of the baby and then extend the head of the baby. When you initially flex the head of the baby, the smaller diameters get delivered and then you extend. But that doesn't mean, अगर हमसे पूछा जाए कि जब बेबी का हेड डिलीवर होता है, by which movement is the head of the baby delivered? So head of the baby is delivered by movement of extension. But initially हम flex इसलिए करते हैं so that smaller diameters come out first, right? And the last thing which it recommends is do not be in a hurry to deliver the head. Go for controlled delivery of the head. So these are all the steps which are recommended by WHO for preventing perineal tear. ऐसे भी question आ सकता है, या for managing second stage of labor. Please remember this step over here, that initially you have to flex the head and then extend along with perineal support. That is what is called as Rittigen maneuver. So with one hand, you will give perineal support. With the other hand, you will flex the head and then extend. Another very important question is, which I am not including over here, everything about episiotomy. Everything about episiotomy is important. Key mediolateral episiotomy, why it is preferred over median episiotomy, what are the structures which are cut in a mediolateral episiotomy. You should know how to recognize an episiotomy scissors. Then you also should be well versed with perineal tear ki grading, right? First degree perineal tear, it involves vaginal mucosa. Second degree का मतलब है vaginal mucosa and muscles torn. Third degree में anal sphincter is torn. So 3A का मतलब है less than 50% of external anal sphincter torn. 3B का मतलब है more than 50% torn. 3C का मतलब है internal and external anal sphincter torn. And fourth degree का मतलब है rectal mucosa torn. All this is very, very important for all of you, right? Now, I think this is the last question for the day, and then we have some spotters for you. So then I have some spotters which you are going to see and tell me what does that indicate. Already this session is for 2 hours. It has gone till 2 hours. So I'm not going to take much of your time now. 15 more minutes, right? True statement for labor care guide is option A, active stage begins at 6 centimeters. Option B, alert and action line are present. The time duration between the two is 4 hours. Option C, second stage of labor represented. Option D, uterine contractions may strength, frequency and duration represented. So tell me, A, B, C or D? True statement for labor care guide. I have started getting your answers. I'm waiting for more answers. So all of you say it's option B. All of you? Anyone with a different option? Someone is saying A, acha. And otherwise, all of you say it's option B. Someone is saying option D. Okay. So D and A I've started getting. Okay. Which means none of you know anything about labor care guide. So yeah, that means कि तुम लोग videos नहीं देख रहे हो. You are not getting updated with whatever updates I am giving. You are not keeping up to date with those updates. But you people feel that being an FMGE, Rajiv Ranjan, very good, Abhijit, good. Now I've started getting the correct answer. Okay, so now understand. Why are updates important? See, you feel that you are going to give foreign medical exam and that is why updates are not important for you. Now, let me tell you, around 2 months back, there was the nursing exam. JIPMER वालों ने nursing exam conduct किया and there was this NORCIT का nursing exam. Before that, I had given these updates right, to the nursing students. And can you beat it? Three questions came from update video which I had taken for the nursing students. And immediately after that, I started getting messages that, ma'am, three questions came from your session. So I don't think so that you people, your standard is going to be below the nursing. You are much above that, bacho. You are a medical graduate. So for you people, keeping abreast with all the updates is very, very important. And I have very high, a lot of respect for foreign medical graduate students. But then I want all of you to have that similar respect for yourself. Don't degrade your exam, don't downgrade yourself, don't think low of your exam. Your exam, the level of your exams is gradually increasing. So you will have to know all the updates, and this is a major update which has come, and that is the next generation partogram. Next generation partogram, which is called as the labor care guide. I don't know how many of you follow me on my Instagram handle, which is Dr. Sakshi Arora Hans. On my Instagram handle also, I have given you update on this, that there is a new partogram which has come, labor care guide. Now for you people, I'm just repeating it over here. That is the next generation partogram, which is labor care guide. अब अभी तक का जो पार्टोग्राम था, जो which you were studying in your classes, that was modified partogram, right? And अब जो नया आया है, that is new, the labor care guide. Labor care guide के नाम से आया है, and this is the next generation partogram. In a modified partogram, active phase began at 4 centimeters, and that is why plotting began at 4 centimeters. According to labor care guide, that means according to latest WHO guidelines, active phase begins at 5 centimeters. So जो ये next generation का partogram है, which is labor care guide, उसमें plotting begins at 5 centimeters. Please remember, according to ACOG, active phase begins at 6 centimeters. But according to WHO's recent recommendations and according to this latest partogram, which is labor care guide, active phase begins at 5 centimeters. जो इससे पुराने वाला partogram था, modified partogram, उसमें active phase began at 4 centimeters. Right? Number 2. In this new partogram, there is a lot of focus which is given on individualizing the intrapartum care. There are no alert lines, there are no action lines. Alert line and action line was present in the previous partogram, which was modified partogram. In a modified partogram, there were two lines. One line was alert line, other line was action line, and the time duration between them was 4 hours. And in modified WHO partogram, alert line kaise banti thi? Alert line was based on the principle that minimum dilatation in active phase is 1 centimeter per hour. अब WHO ने ये सारा कॉन्सेप्ट हटा दिया. WHO कहता है it is not necessary that in active phase dilatation should be 1 centimeter per hour. And that is why जब उसने ये कॉन्सेप्ट ही हटा दिया कि now in active phase dilatation can be less than 1 centimeter per hour. So obviously the alert line is gone, because alert line was based on the fact that in active phase minimum dilatation is 1 centimeter per hour. अब जब ये कॉन्सेप्ट ही नहीं रहा तो alert line चली गई, and since there is no alert line, there is no action line, right? So in this new partogram, there is no alert line, there is no action line. According to this new partogram, active phase में dilatation can be less than 1 centimeter per hour. Very, very important. So there are time-based cutoff for each centimeter dilatation of the cervix. So now there is a time-based cutoff. अब ये general rule नहीं है कि dilatation has to be 1 centimeter per hour. For every dilatation, there is a time-based cutoff in this partogram, right? जो इससे पहले वाला partogram था, that is modified partogram. In modified partogram, second stage of labor was not represented. right? Whereas over here, the second stage of labor is also represented and monitoring is done with the second stage of labor also. And jab bhi female push karna start karti hai, it is represented by letter P. So these are all differences which are there between the new partogram, that is labor care guide, and the earlier partogram, that is modified WHO partogram. Then in the new partogram, there is a supportive section, and इस supportive section में हम mention करते हैं कि pain relief के लिए patient को क्या दिया, in which posture was delivery conducted, because WHO says delivery can be conducted in any posture. How much was the oral fluid intake which was given to the patient? Please remember, WHO says that oral fluid can be given to a patient during labor, but solids avoid करने चाहिए, right? And because WHO says कि oral fluid दिया जा सकता है, that is why it is represented on partogram now, that is labor care guide. Then WHO makes it mandatory that every female who is delivering should be accompanied by one companion of her choice. So you also have to mention there who was the companion who was there during the delivery. Then comes uterine contraction. जो मॉडिफाइड WHO पार्टोग्राम था उसमें जब हम यूट्राइन कॉन्ट्रैक्शन को रिप्रेजेंट करते थे, वी टोल्ड द ड्यूरेशन, द फ्रीक्वेंसी एंड द स्ट्रेंथ ऑफ द कॉन्ट्रैक्शन. बट नाउ इन दिस न्यू पार्टोग्राम विच इज लेबर केयर गाइड, ओनली ड्यूरेशन एंड फ्रीक्वेंसी इज टोल्ड. You don't have to mention the strength. Now tell me, how many of you are aware that the earlier modified WHO partogram mein how was uterine contraction represented and how was the duration represented? So uterine contraction को represent करने के लिए there were boxes. Each box corresponded to one contraction which happened in 10 minutes. So for 10 minutes, you had to put your hand on the patient's uterus and you had to count the number of contractions. If in 10 minutes there were 3 contractions, you would color 3 boxes. If there were 2 contractions, you would color 2 boxes. Not only this, the way in which you color told the duration of the contraction. So if you colored in dots, it meant that the contraction lasted for less than 20 seconds. If you made oblique lines, it meant that the contraction lasted for 20 to 40 seconds. And if you did a solid coloring, that means the contraction lasted for more than 40 seconds. So number of boxes जो आप color कर रहे हो and how you are coloring told about the duration and frequency of contraction. Along with that, अगर हमारे पास टोको dynamometer available होता था, then we used to measure the strength and we used to write it. Now they say there is no need to write the strength. You just have to follow the same principle about duration and frequency. Clear to all of you? So these are the differences between modified WHO partogram and WHO's labor care guide. This is there on my Instagram handle. You can go and read it from there also. Right? This is a table which I want all of you to quickly take a screenshot. I don't have much time. So I am going to just wanting all of you to take a screenshot of this table where I have written the stages of labor, their average duration and their maximum duration. Over here please understand कि जो WHO का latest है, जो modified का मतलब जो latest है, it is according to the latest thing. WHO says that the dilatation can be less than 1 centimeters per hour. So WHO says in active phase now the dilatation can be less than 1 centimeter per hour. Earlier WHO कहता था कि minimum dilatation should be 1 centimeter per hour. But now it says it can be less than 1 centimeter per hour. Modified WHO guidelines. These are the new guidelines based on which labor care guide is made. Older WHO guidelines was that the latent phase was up till 3 centimeters. Right, so latent phase was up till 3 centimeters and active phase began at 4 centimeters. नाउ WHO की जो लेटेस्ट है वो ये कहता है कि नाउ WHO सेज द लेटेस्ट गाइडलाइन से कि एक्टिव फेज बिगिंस एट 5 सेंटीमीटर्स. पहले WHO कहता था कि एक्टिव फेज बिगिंस एट 4 सेंटीमीटर्स. नाउ इट सेज दैट एक्टिव फेज बिगिंस एट 5 सेंटीमीटर्स. ACOG क्या कहता है? दैट एक्टिव फेज बिगिंस एट 6 सेंटीमीटर्स. All these three things you have to remember. कि जो प्रीवियस वाला पार्टोग्राम था विच वॉज कॉल्ड एज मॉडिफाइड WHO पार्टोग्राम विच वॉज बेस्ड ऑन ओल्डर गाइडलाइंस, वहां पे एक्टिव फेज बिगैन एट 4 सेंटीमीटर्स. जो लेटेस्ट WHO की रिकमेंडेशंस हैं जिसपे लेबर केयर गाइड इज बेस्ड ऑन, वो कहता है कि एक्टिव फेज बिगिंस एट 5 सेंटीमीटर्स एंड ACOG सेज दैट एक्टिव फेज बिगिंस एट 6 सेंटीmeters, right? So don't get confused by modified WHO guidelines. Instead, you can remember latest WHO guidelines, because modified term से you can get confused. Modified term use होता है modified WHO partogram बोलते हैं. Modified WHO partogram older guidelines पे based था. राइट एंड जो नया पार्टोग्राम आया है नेक्स्ट जनरेशन पार्टोग्राम वो लेटेस्ट गाइडलाइंस पे बेस्ड है. So you, instead of writing modified WHO guidelines, write it as latest WHO guidelines. Clear? So this all is over here. I want all of you to take a screenshot of this table. This is a very, very important table about stages of labor. Spotters. In spotters, this image A, this is a snowstorm appearance which is seen on ultrasound and in the uterus. And this particular snowstorm appearance you get in case of complete mole. Image B over here is cannonball appearance, which you get in case of choriocarcinoma when choriocarcinoma has metastasized to the lungs. Please remember, whenever choriocarcinoma metastasizes to the lungs, that is stage 3. And the most common presentation of choriocarcinoma metastasis is a cannonball appearance. And if cannonball appearance is not there, then on chest X-ray, the second most common appearance is snowstorm appearance, right? Then over here is again, I am saying image A and B, and you have to tell me in this spotter, how are you going to identify which one is uterine inversion and which one is uterine prolapse? So tell me A and B mein se which one is uterine inversion and which one is uterine prolapse? Quickly, I'm waiting for your answers. How are you going to tell me which one is uterine inversion, image of uterine inversion, and which one is the image of prolapse? Okay. So again, I've started getting varied answers over here. So you are going to recognize with the help of the os. If os is visible, it means it is prolapse. If os is not visible, then that means that is uterine inversion. Clear? Simple funda. Os is visible, it's prolapse. Os not visible, it is inversion. Tell me which instrument is this? Quickly, a spotter. Which instrument? And where it is used? This is a Carmen cannula. Very good. Right? And what size Carmen cannula are you going to pick up for doing suction evacuation? This is used for suction evacuation. Suction evacuation, when is it done? It is done between 7 to 12 weeks of pregnancy, right? And the size of Carmen's cannula should correspond to the period of gestation, right? Then what is the intrauterine pressure which is generated during during suction evacuation? 600 millimeters of mercury. That is the pressure which is generated while doing suction evacuation. Okay. Now tell me which is this spotter. What is this ultrasound image showing you? See the spotter over here. What is this ultrasound image showing you? This image is a double decidual sac sign. Double decidual sac sign is seen in case of intrauterine pregnancy. Prasan, this is not double bleb sign. Double bleb sign may, if you go to the revision videos which I am taking on my channel, I have shown you there. Double bleb sign में you will see a gestational sac, and gestational sac में you will see two bubbles. यहाँ पे what you are seeing is a gestational sac which is surrounded by two ring like structures. One ring is this ring which is pointed, which is the inner arrow, the thinner arrow is pointing, and the other one is this ring which a thicker arrow is pointing. So जो inner वाली ring है, this is decidua capsularis, and जो बाहर वाली रिंग है, this is decidua parietalis. So this is double decidual sac sign or double decidual ring sign. Clear? This is double bleb sign. Double bleb sign में one is yolk sac and the other one is amniotic sac. Clear? Okay. Now tell me, what are these instruments? A, B and C. A is Ayer's spatula. B is endocervical brush. And C is a cervical brush or a cervical broom, which is used for liquid-based cytology. It is used for liquid-based cytology. That is liquid-based pap smear. These two are used for conventional pap smear. Right? With the Ayer's spatula, you are going to take sample from transformation zone. With endocervical brush, you are going to take sample from endocervix. Both these samples are put on a single slide, right? And you are not going to air dry the slide. And what is the fixative which is used? Fixative which is used is 95% ethyl alcohol plus minus 5% ether. Ether can be given in your options. It may not be given in your options, right? What is this spotter over here? So what spotter can you see over here? What are you seeing over here? You are seeing some mass and you are seeing hair in it. You are seeing teeth in it. Whenever you get a mass where you are seeing hair and teeth, that means it's a teratoma, and this is a dermoid cyst. Right? A dermoid cyst is a yolk sac tumor of the ovary. Right? Very, very important is dermoid cyst. What is that area, raised area from which these elements arise? That is called as Rokitansky protuberance. Right? Which is the most common benign tumor of the ovary? It's a dermoid cyst. Dermoid cyst is the most common benign tumor of the ovary. It is the most common tumor to undergo torsion during pregnancy. And because dermoid cyst can undergo torsion, that is why we have to remove it. Gestational, no bacha. Gestational sac sign cannot differentiate between intrauterine and ectopic pregnancy. It cannot. For more details, you will have to go through the revision video part 1, which I have put on my channel for all the FMG students. Now, what is this spotter over here? Again, in this spotter, this is image A, this is image B. Now, in image A, what I'm seeing one twin, I am seeing second twin, right? But and over here again, one twin sac, the second twin sac, right? But the difference is over here, I am seeing that the placenta is coming in between the two twins in the form of a peak, right? This is what is called as twin peak sign positive, or this is called as lambda sign positive. And this is seen in dichorionic diamniotic twin pregnancy. Over here, this is the placenta, and placenta is not coming in between the twins. And that means this is twin peak sign negative. And this means this is monochorionic twins. Because I am seeing a thin membrane over here, this means this is monochorionic monoamniotic. If no membrane would have been seen, monochorionic, this is monochorionic diamniotic. And if no membrane would have been seen, it would have been monochorionic monoamniotic. You don't have to worry about whether it is monochorionic diamniotic or monochorionic monoamniotic. You simply have to, recognize the twin peak sign. Twin peak sign, if it is present, it is dichorionic. If twin peak sign is absent, that is monochorionic. That is more than sufficient for you. When do you do ultrasound to determine chorionicity? Between 11 to 13 weeks. So you will have to do ultrasound between 11 to 13 weeks to detect chorionicity, right? Then identify the fetal presentation. Now, this is a question which all of you tend to make mistakes with. Now, this is very, very important. Now, over here, first thing what you have to do is you have to identify where the occiput will be. Right, so somewhere here will be the occiput of the baby. This over here is pubic symphysis. Over there will be the sacral promontory. Now, first thing first, tell me, where is the occiput facing? Is the occiput towards pubic symphysis more, or is it towards sacral promontory more? This is more towards pubic symphysis. This means this is occipito anterior position. If it would have been more towards sacral promontory, I would have said occipito posterior. But just now the occiput is more towards pubic symphysis, so this is occipito anterior position. Now, whenever you get a question like this, please remember, when we are conducting vaginal delivery, we are looking towards the face of the mother. So my left is mother's right, my right is mother's left. So in this image, occiput is towards your left or towards your right? It is towards your left. So if it is towards your left, it will be mother's right. So this is going to be right occipito anterior position. Now, if you get a question like this where they have shown you the occiput, it's very easy. Sometimes they may give you a question like this where they have not shown you where the occiput is, but all of you know that occiput is lying just above the posterior fontanelle, just below the posterior fontanelle, and posterior fontanelle is the triangular looking fontanelle, right? So posterior fontanelle ke just niche is the occiput, and posterior fontanelle is the triangular looking fontanelle. So if you get an image like this, look, where is the triangular looking fontanelle? Is it towards pubic symphysis? Is it towards sacral promontory, or is it in the center? So I can see that the triangular looking fontanelle is exactly in the center. That means it is occipito transverse. If it would have been towards pubic symphysis, I would have said occipito anterior. If it would have been towards sacral promontory, I would have said occipito posterior. But it is in the center, so it is occipito transverse. Now tell me whether it is towards your right or towards your left. It is towards your right, it is towards my right. In other words, it is mother's left. So this is left occipito transverse position. Clear to all of you? Very, very important image. Then the next important image is the Leupold-Menuers image. Very, very important. All of you know that there are 4 Leupold-Menuers. First 3 are done while you face the face of the patient. In the first maneuver, which is called as the fundal grip, your hands are going to be on the fundus of the uterus, and it tells you about the lie, because if this fundal grip is empty, it means it's transverse lie. If something is present, that means it's longitudinal lie. Now also it tells you about the presentation. अगर हमें ऊपर की तरफ something soft feeling आ रही है, broad feeling आ रही है, that means buttocks are present up. In other words, it is cephalic presentation. And अगर ऊपर हमें hard rounded globular structure मिल रहा है, it means head is present up, that means it is breech presentation. Then comes this, then from the fundus you move your hands towards the lateral side, and that is what is called as lateral grip or umbilical grip. Lateral grip or umbilical grip tells you about the position of the baby, right? Then you bring your single hand towards the pelvic area. That is the third maneuver, which is called as pollic grip. Pollic grip tells you about the presentation, plus it tells you whether the head of the baby is fixed or floating. अगर बेबी का हेड मूव हो सकता है from one side to other side, that means it has not yet entered the pelvis. And if it cannot be moved, that means it has entered the pelvis, right? Then comes the fourth the fourth Leopold's maneuver, which is called as deep pelvic grip. For deep pelvic grip, you are now going to face the feet of the patient, and with your two hands, you are going to keep them parallel to the inguinal area, and you are going to feel what you are getting in the pelvic area. So it confirms the findings of the third grip. So it is again going to tell you about presentation. It is also going to tell you whether the head of the baby has gone down into the pelvis or not. Plus, it tells you one more thing, and that is attitude of the baby. So deep pelvic grip tells you everything what third grip tells you, right? So which what the third maneuver tells you, that is the pollic grip tells you. Along with that, it also tells you about the attitude of the fetus. Clear to all of you? Yes. Then important images are maneuvers in breech. These are very, very important images. Number one image which you are seeing over here, you are giving traction to the groin area. So this is groin traction, which is done for delivery of buttocks in case of a flexed breech, right? Then you have second maneuver which you are seeing over here is Pinard maneuver. In Pinard maneuver, finger is being taken up till the popliteal fossa. So P for Pinard, P for popliteal fossa. If you see fingers being taken up till the popliteal fossa, that is a Pinard maneuver, which is done for delivery of legs in case of a frank breech, right? Then comes the another maneuver where you are seeing कि hands are kept on the back of the baby. Baby के legs deliver हो चुके हैं. Now we have kept hands on the back of the baby and we are trying to rotate the baby so that the shoulder of the baby delivers. This is called as Lovset's maneuver, which is for shoulder delivery, right? And then comes the last part to be delivered in breech is head, and that is why it is called as after coming head of breech. For delivery of head, you can let the baby hang by its own weight. Then you can take the legs towards the mother's abdomen. This is what is called as Burn Marshall technique. Please remember, in a normal vaginal delivery, head of the baby is delivered by movement of extension. But in case of breech, head of the baby is delivered by movement of flexion. What is the most common cause of death in breech? Intracranial hemorrhage, right? There is another way for delivering the head of the baby, and that is malar flexion shoulder traction. इसमें क्या दिख रहा है? इसमें you are seeing two fingers are kept on the cheek of the baby and two fingers of the other hand are put on the shoulder, and you are doing malar flexion shoulder traction, right? So your one hand's fingers will be on the cheek of the baby, other hand fingers will be on the shoulder. Another name for this is what is malar flexion shoulder traction, right? This is also what is called as Morrissey Smiley wheat technique, right? So this is a technique by which you can deliver the head of the baby. A third way of delivering the head of the baby in breech is by using a forceps, which is called as Piper's forceps. Now, in all these methods, the back of the baby is anterior. In other words, these are methods for delivery of dorso-anterior breech. But agar मान लो it's a dorso-posterior breech and head की delivery करानी है, then in that case, the maneuver which you use is Prague maneuver. Only the name, Prague maneuver. So these were the three methods. Number one, Burn Marshall. Number two, Morrissey Smiley wheat technique. Number three, Piper forceps. These were three methods for delivery of head in dorso-anterior breech. Can you see over here? In all these cases, the back of the baby is facing anteriorly, right? But if the back of the baby is facing posteriorly and I have to deliver the head of the baby, then the maneuver which you use is Prague, Prague, Prague maneuver. No need to know the details, just this much for Prague's maneuver, right? Now last thing which you have to know, two very important scores in OBGY. इनमें से जरूर question आता है. One is Bishop score, and I'm sure you know Bishop score is for induction of labor, and what are the parameters which are used for Bishop score. As far as FMG exam is concerned, you don't need to know how to calculate the score. You just need to know what are the parameters which are included in Bishop score, that is Delhi Police Employed Special Commandos, where D stands for dilatation of the cervix, P stands for position of cervix, E stands for effacement, S stands for station of fetal head, and C stands for consistency of the cervix. Now, a total score जो maximum हो सकता है, that is 13. If score is more than equal to 9, that means there is maximum success for induction of labor. And if score is less than equal to 5, then that is a poor score, right? Now, so Bishop score is important. Now there is something which is called as modified Bishop score. In modified Bishop score, effacement of cervix is replaced by length of cervix, right? So this parameter effacement ki jagah there is length of cervix, right? And length of the cervix ko measure karne ke liye you will have to do TVS. In other words, Bishop score ke liye there is no need for doing a TVS. It's a clinical score. Modified Bishop score के लिए you need to do a TVS or an ultrasound, because in modified Bishop score we look at the cervical length. Pavitra, yes. For NEET PG, you have to know how to calculate the score, because they give you a condition and they will ask you what is the Bishop score. FMG के लिए no need to remember the calculation, but for NEET PG, it is very, very important for you to know how to calculate Bishop score, right? Then a second score which is very important for all of you is biophysical score or Manning score, which is done for 30 minutes by ultrasound. When do you do a biophysical score or a Manning score? So suppose a female comes to you with decreased fetal movements. So when a female comes to you, एक minute, Mr. Serotonin, just wait, just hold on to your doubt. I'll just now come to that. First, let me complete what I'm telling. Whenever a female comes to you with decreased fetal movement, so if a pregnant female complains of decreased fetal movement and they ask you what is the next step, so next step is a screening test, right? And what is that screening test? The best answer would be modified biophysical score. अगर ये ऑप्शन में नहीं दिया है, then the second best answer is NST, right? Remember, modified biophysical score mein there are only two parameters at which you look. One is NST, the other is amniotic fluid volume, right? And इनमें से अगर कोई भी टेस्ट abnormal आएगा, then you go for diagnostic test, and the diagnostic test is biophysical score, right? Biophysical score is a diagnostic test. Modified biophysical score is a screening test. Modified biophysical score mein there are only two parameters, NST and amniotic fluid volume. Biophysical score mein there are 5 parameters. TB, meningitis, always notorious, where T stands for fetal tone. And जब भी हमने biophysical score or Manning score we have to do, then you have to do ultrasound for 30 minutes. And in that 30 minutes, you have to note how was the fetal tone. How are you going to note how was the fetal tone? If there is one more than equal to one movement of extension and flexion, you will give a score of +2. एक बार भी baby का in 30 minutes move hand bent out for flexion, extension and flexion, you will give a score of +2. Then comes breathing movement. So if in a period of 30 minutes, there is one episode of breathing, actually that breathing is chest wall movement. So if there is even one episode of chest wall movement, I will give a score of +2. Then in a period of 30 minutes, if there are 3 gross body movements, I will give a score of +2. Then I will look at the single largest vertical pocket. If there is single largest vertical pocket, if it is 2 centimeter pocket, I will give a score of +2. I will do an NST, and if NST may I am getting 2 or more than 2 accelerations, I will give a score of +2. So maximum score which you can get is 10 by 10. So if you are getting a score of 10 by 10, that means the baby is absolutely fine. Clear? So for all the FMGs, you just need to know biophysical score or Manning score. What are the parameters? What are there in biophysical score or Manning score? Uska interpretation you don't need to know. Similarly, for Bishop score, you need to know what is there in Bishop score, and score agar more than 9 hai to kya matlab hai? Score if it is less than 5, what does that mean? Clear? Now, if NEET PG students are watching this video, you also need to know one more score, and that is WHO's scoring for choriocarcinoma. That's very, very important. WHO scoring system for gestational trophoblastic neoplasia, right? Okay, Mohit, important physiological changes. Important physiological changes for FMG are cardiac changes, very, very important. Hematological changes, very, very important. And respiratory changes, right? Sri Lakshmi, is it enough to do 6th edition revision videos and MCQ discussion for FMG? Now, if you are going to rely only on revision videos and MCQ discussion, then I would say that do revision videos, MCQ discussion plus today's session, whatever I have told in today's session. And there are 3-4 sessions which I am taking on YouTube for all the FMG students before you give your exam. Watch those sessions, that will be more than enough. Yes, Wish. There was some technical issue which happened while I was delivering this YouTube lecture edition part 3, OBS part 3. So I couldn't save that video. I will again do a live OBS part 3 video on my YouTube channel. Then I'll save it also for all of you. Right? Any other questions which you have? Now I'm quickly taking you through for list 1 of OBS. So these are the topics which you have to take a screenshot. These are the topics which are highly essential for OBS, in OBS for FMG exam. You keep a list, take a printout of this list, right? And the moment these topics are done, put a tick around them. Right, just tick them out that I have done all these topics. Be sure that each one is ticked before you attempt your FMG exam, right? This is list 1. List 1 means most important. Then this is list 2. Once you've done list 1, then these are the topics which you are going to do. Iske alawa, don't do anything just now in OBS, right? List 3 I'm not showing you because you don't have time, so don't do list 3. Just first do list 1 and then do this list 2, right? Then gynae list 1. These are the topics for gynae list 1. Most important topics for gynae, right? Once you take a printout of this list, just put a tick mark the moment you cover all these topics. So this is gynae list 1. And this over here is gynae list 2. Iske alawa, do nothing in OBS and gynae. Now, if you are a Marrow subscriber, let me clearly tell you how you are going to prepare. If you have done OBS from FMG, OBS from edition 5, simply you are going to watch revision videos of edition 6, today's class and MCQ discussions. That's more than enough for OBS. Nothing is going to come beyond it. If you have not watched any video of OBS and Gynae till now and you are a Marrow subscriber, in that case, watch the revision videos, watch the MCQ discussion videos, watch today's session, and uske baad is list se compare karo. If there is any topic which is not being covered in from those 3 things, today's session, from OBS, from MCQ discussion, and from revision videos of edition 6, then that particular topic video you should watch, right? So all the best to all of you. See, Bacho, you didn't come this far to come only this far, right? You have come this far because all of you want to clear your FMG, and not just FMG. You all have to clear your NEET PG as well. And that is why I want all of you, to be making the best use of this time and giving your best shot this year. All the best to all of you. Thank you so much. Take care. Bye.